Preoperative care. Surgery interrupts the natural physiological processes of the body, and it causes stress and risks for complications. This is basically a trauma to the body. Variables that affect surgery include the procedure that's being performed, the age of the client, and any coexisting medical conditions, aka comorbidities, and these things all go together to determine how quickly a client will recover from or potentially any complications that client may experience. As far as age, we know that clients over the age of 70 are at an increased risk for surgical complications. Now, this doesn't mean they will have surgical complications, it's just their risk has been increased. Older adults also can respond differently to anesthesia and the drugs used during surgery, and they can also take longer to wake up from the anesthesia. A client's nutritional status is a factor. Clients that are overweight or underweight require special care if surgery is indicated. Underweight clients may have increased problems with wound healing and infection, while overweight clients are going to be more likely to have respiratory and wound complications. Think about it. Adipose tissue, that fat tissue, has poor perfusion, so the healing process is going to be slower. And adipose tissue will hold on to the anesthesia longer. So the overweight client may remain sedated longer. And add that to the effect that they have less room for the diaphragm to expand, so they're not able to take those deep breaths like they would otherwise. So let's look at the types of surgery. We have diagnostic surgery. This is done to complete or is completed to make an accurate diagnosis through removal and study of the tissue or opening of a body cavity to determine the extent of a disease process, or can be performed through the use of a scope. Excuse me. Exploratory surgery is a more extensive surgery to diagnose an issue. It's basically diagnostic surgery, but it's just an extensive diagnostic surgery. Curative surgery involves removal of diseased tissue, replacement of defective tissue to help restore function, or to repair wounds. Palliative surgery is performed to relieve symptoms or improve function without correcting the problem. In other words, we know a client has, let's say, terminal colon cancer, and the tumor has now created an obstruction, so now they're no longer able to defecate. So we have a blockage. Well, we do surgery to remove the blockage or to allow for the client to defecate, whether it's through an ostomy or the rectum. But the original problem is still there. It doesn't go away. Cosmetic surgery will improve a person's appearance. Preventative surgery can remove non-cancerous tissue that has a high probability to become cancerous. For example, some of the genetic factors are now determined through blood work to determine if a woman may be at a high likelihood of contracting certain breast cancers. And if it comes back positive, some of these women will choose to have a prophylactic mastectomy to remove the tissue before a cancer can develop. So that would be preventative surgery. Reconstructive surgery is done to restore function or structure, either one. And procurement would refer to the removal of organs for a transplant. Surgeries can be completed in a variety of settings other than inpatient hospitals. There are ambulatory or outpatient surgeries. These are increasing in number due to advanced surgical techniques and anesthesia, reimbursement, managed care, changes in Medicare, and they actually allow a client to be discharged within a few hours or the following morning of the procedure. During the preoperative phase, nursing goals are to help minimize the client's anxiety, prepare the client for surgery, monitor for complications during surgery, and assist in an uncomplicated recovery. So the last two incorporate intraoperative and postoperative. 3 phases of surgery include preoperative, intraoperative, and postoperative. That preoperative phase will begin when the decision to perform surgery is made and will continue until the client arrives at the operating room. The intraoperative phase will start when the client reaches the operating room and ends when the client is moved to the recovery room. Then the postoperative phase will begin when the client is admitted to the recovery room until the client has a follow-up evaluation with the surgeon. Depending on how soon the surgery is to be completed, the nurse may only have a very short period of time to prepare the client for surgery. So part of the assessment is going to be completing preoperative labs and diagnostic studies. So making sure that we're getting that CBC or the chest x-ray or the UA done, etc. Reviewing preoperative instructions, which include a diet and skin preparation. Identifying any risks that are related to the client's age, their nutritional status, their use of alcohol or tobacco, and their overall physical condition. The nurse then will also perform a history and physical examination. Now, the provider performs a really complete one, but nurses have to do their part too. And we need to assess the client's understanding of surgery. The surgeon is responsible for providing the education regarding the procedure itself as to why it's necessary, what alternate procedures could be available, what are the risks and benefits of the procedure, what are the consequences of not having the procedure, etc., etc. That is the surgeon's responsibility. As nurses, we can reinforce that education, but it's not our responsibility to provide the education. We're also going to consider cultural needs, beliefs, disposal of body parts, and blood transfusions. For example, the Jehovah's Witness religious beliefs mean that they cannot have any blood transfusions. So we need to look at all of those aspects. We also need to make sure that an informed consent is obtained. When the informed consent is complete, it indicates the client consents to a procedure and understands the risks and benefits of the procedure. It's going to be required for all invasive procedures that require anesthesia and or has risks of complications. For it to be a valid informed consent, it has to be voluntary. It cannot be coerced. The client has to be over 18 years of age, and it has to be obtained before the client receives any mind-altering medications. Let's say, for example, we have a client who comes in with a suspected appendicitis, and they're in significant pain. We cannot medicate them for the discomfort until we have gotten that informed consent obtained. If an incompetent client, let's say a client who has cognitive impairment, they may be mentally ill or neurologically incapacitated, this informed consent is often signed by a family member, such as a parent or the client's guardian. And minor clients, unless they are emancipated, must be signed by a parent or guardian. And this is through the age of 18. The signature will require an adult witness, and the nurse is the one who's responsible to have that signed consent on the client's chart. Again, the surgeon, the provider, is the one who will provide all of the education. It is up to the nurse to make sure that these criteria have been met, make sure that the signature is on the paper, and make sure that it is appropriately witnessed. Client teaching is best accomplished during the preoperative period in order for the client to demonstrate adequate knowledge of the surgical procedure, the preoperative, intraoperative, and postoperative procedures, so the client's better able to participate in those required procedures. And ultimately, that can lead to a shorter recovery period. Preoperative Some of the teaching will include preoperative and postoperative medications and pain control. It may include a description of post-anesthesia area and routines. It may include a discussion of the frequency of vital signs and monitoring equipment. This is where we also explain and demonstrate deep breathing and coughing exercises, the use of incentive spirometry, splints, leg and feet exercises, and encourage return demonstrations. By splinting, I'm talking about if the client has abdominal surgery, for example. This is where we use a small pillow or a folded blanket or just the client's hands to provide some counter pressure on the abdominal incision. It helps provide some stability and also helps decrease pain when the patient is moving postoperatively. So we can demonstrate that prior to the actual surgical procedure being performed. We can inform the client of intravenous fluids and anticipated drainage tubes. Now, we don't know what they're going to come out of surgery with until surgery is performed. But if it is a procedure that typically has drainage tubes, then we can at least talk about them. It's also a time to allow the client to express their anxieties and their fears. We also need to make sure that we include family members in preoperative explanations. But be aware that in emergent situations, we kind of have to pick and choose what we can get done in the time that we have before the client is whisked away to the operating room. So we provide as much teaching as possible in that time allotment or as we're able, depending on the client's alertness or their cognitive status. With the older adult, make sure that you realize that they may have diminished abilities to hear, see, and understand that can interfere with the preoperative and postoperative teaching. So it may be important to repeat explanations and demonstrations, not to rush through your explanations, include those family members, be aware of any cognitive changes due to pain, medications, or change in the environment, and when able, use that teach back technique. This helps make sure that the client understands and clarifies areas that need to have further explanation. Excuse me. This is a mnemonic to help you remember some of the procedures. So physical preparation. Some procedures will require skin preparation several days prior to surgery. This may require the client to bathe with a germicide soap or to shave. Uh, Hair removal typically is not done unless it may interfere with the incision due to potential microabrasions from the razor. And if hair removal is necessary, it's usually done with an electric razor. Elimination. The client may require insertion of an indwelling urinary catheter, or as the client is being called to surgery, the client will go to the bathroom and void prior to getting in the wheelchair or on the gurney to go to the intraoperative area, or we have them void prior to the administration of any preoperative medications, especially ones that may interfere with the client's safety if they were to get out of bed. We may also need to do enemas or laxatives prior to them going to surgery, especially if surgery is going to be done on the bowel or areas that having feces within the bowel may potentially contaminate the operative site. As far as food and fluids, most clients who are going to have a surgical procedure will be NPO or nothing by mouth for approximately 8 to 10 hours prior to surgery. Now, be aware that there's some surgical procedures that may allow the client to have clear liquids for up to 2 hours prior to the surgery. But this would be determined by the surgeon themselves and not by the nurse. And also be aware that some clients have medications that may require them to take their morning medication before the surgical procedure, such as beta blockers, for example. The client should be taking those before they go to surgery, but they just take them with a small sip of water, just enough to get the pill down. And postoperatively, the client should have an adequate intake of protein and ascorbic acid, the vitamin C, for proper wound healing. As far as their valuables, if we have the opportunity preoperatively, we tell the client, leave all the valuables at home. There's no need to bring them to the hospital with you. But if they do, we can hopefully give them to a family member to be in charge of while the client is in the hospital. Or if that's not a possibility or the client does not want that, we can put them in a valuables envelope. And that would require us counting any money or describing any items that are going in the envelope in the client's presence. And just an FYI, we never, ever, ever write down a diamond or gold or silver, because this indicates a value attached to something, and it may not be a diamond. It may just be zirconium. So we always put down white stone, yellow metal, white metal. So just an FYI. Now, there's some people who like their wedding rings, for example, they're just not able to get them off anymore for the simple fact that maybe there's some edema, or maybe their hands have enlarged in size slightly, or the client is just really reluctant to remove it. Then we wrap gauze around the ring, or we cover it with adhesive tape. This helps prevent any burns from the electrocautery knife that may be used during the surgical procedure. We should also remove the client's glasses or contact lenses prior to surgery. Now, some clients are going to have things like prostheses, such as a false eye, or let's say a prosthetic limb, or even dentures, or hearing aids. And sometimes these are important for the client to keep those with them until the surgical procedure. And in those cases, we just notify whoever we're doing handoff report to that those still remain in place. As far as attire, the client will generally wear a hospital gown and a cap to cover the hair. And of course, the gown should not contain anything metal, so no snaps. All makeup and nail polish should be removed. It's not necessary for people to come in with their nails done, with their makeup immaculate, etc., because they're going through surgery. And we may get inappropriate oxygen saturation readings if nail polish is on. There's some nail polishes that will not allow for appropriate readings or accurate readings. If it is an ambulatory surgery, only portions of the clothing, makeup, or polish may need to be removed. So let's say we're going to operate on the client's foot or their knee. They could probably leave their underwear on unless they're going to have a urinary catheter inserted, which on ambulatory surgeries is not likely. And some clients or some surgeons will require anti-embolism stockings, aka those TED hose, or if the client is too large for TED hose, elastic wraps may be required preoperatively to help prevent the formation of blood clots. Again, especially hearing aids should remain in place until the client is being put to sleep, so the client can understand any instructions that may be given. As far as preoperative medications, this can include anti-anxiety medications, histamine 2 receptor antagonists, anticholinergics, opioids, sedatives, and/or antibiotics. If it is a mind-altering medication, then we should, again, always make sure that the client has gone to the bathroom prior to receiving this medication. But for safety, we always follow the patient rights for medication administration, making sure that you're checking for drug allergies, monitoring the client's vital signs, and making sure that surgical consent has been signed. And then the client should remain in bed with the side rails up for safety and the call light within reach. Now I realize that the rails can be a violation of restraints because having all of the rails up can be considered a restraint. But let's say we do this in the intraoperative area prior to them going into the actual operating room, so the holding area. You have a nurse who is readily available, so they are watching them very closely. Those situations are not necessarily considered a restraint. Psychosocial preparation should begin as soon as the need for surgery is determined. Preoperative teaching and listening helps calm the client's fears and anxieties. We need to assess their coping methods and contact any religious sources, clergy, or chaplain if requested. We complete a preoperative checklist to help assure that all preoperative needs and procedures have been completed. The nurse's role includes making sure the assessment has been completed, including disposition of valuables, making sure they have appropriate attire for OR, making sure that preoperative medications have been administered, that an IV and ordered solutions have been initiated if ordered, preoperative preparations, including all the necessary paperwork. The emphasis is going to be on the right procedure at the right site, and the client should be involved in the process as possible. In other words, we go in and, okay, so today we're going to be operating on your right knee. Is this correct? And the client confirms or denies that this is the appropriate area. Then we take a marker that is a non-washable marker and mark the site. Or sometimes the surgeon will actually do this themselves and initial the site. Then prior to the actual initiation of the procedure, the client is in the operating room, the client is on the table, all the members of the operative team are there. A timeout is initiated to make sure that the client is the correct client, that the operation is intended on the appropriate site with the appropriate procedure. Again, kind of going through some of the items that may be on the checklist. Each facility's checklist will be just a little bit different. A surgery which the client will not be harmed if the surgery is not performed, but will benefit if it is performed, is called this is an elective surgery. And your post-test.